We can move to the next speaker. I'm pleased to introduce Dr. Qutaiba Abdullatif Hussain from United Arab Emirates. Professor Qutaiba is currently the Chief Medical Officer of Home Hemodialysis Healthcare at Abu Dhabi in United Arab Emirates. He is lecturer in Emirate University, and he has more than 20 years of experience in nephrology service, and his main interest is hemodialysis, peritoneal dialysis, and kidney transplantation. His talk will be about reaction to hemodialysis membrane. Are they worth your attention? So please, Dr. Qutaiba.
Thank you. Thank you, Mr. Chairman. Thanks for the organizing committee for this kind invitation. Without delay, I will start my lecture. So my lecture will be the outline, introduction, case presentation, definition, and type of hemodialysis membranes, mechanism and types of reaction, and thrombocytopenia with case and diagnosis, management, and conclusion. So we have a 25 years old female who had diagnosed with hypertension and end-stage renal disease January 2020 and started hemodialysis. However, she had been non-compliant and had recurrent admission for hypertension emergency with or without pulmonary edema. In October 2021, she was admitted through ER with hyperkalemia, uncontrolled hypertension, systolic more than 200, diastolic 140, and pulmonary edema after missing hemodialysis for 1 week. During the urgent hemodialysis session, she was symptomatic with fatigue, generalized body ache, headache, nausea, vomiting, itchiness, and restlessness, and severe hypertension. You know all the patient will be relieved in about 20 minutes, and contrary, this patient becoming worse. So our fellow noticed that she had chronic hypereosinophilia and relative thrombocytopenia started after initiating renal replacement therapy increased with time. You can see her absolute eosinophil count is high in many occasions, as well as her platelet count even reached less than 50% from normal. So the diagnosis of membrane reaction, polysulfone membrane, was suspected, and dialyzer was changed to PMMA, polymethyl acrylate membrane. The next dialysis, she was well and tolerated. We decided to re-challenge her with polysulfone dialyzer after taking her permission. Again, after starting dialysis, she was complained of feeling unwell, nausea, vomiting, itchiness, and autocyte was 98% good. Then complaint of severe chest pain, shortness of breath, wheezes, hypertension. Dialysis was terminated for sure, and chlorpheniramine 10 milligram given and hydrocortisone. What happened to white PC? In the it usually a little bit increased upon the starting dialysis, but we usually see a dip in 15 minutes with neutropenia. This neutrophil usually sequestrated in the pulmonary circulation. So she is labeled allergic to polysulfone, and it was clear that the reason of her non-compliance with hemodialysis treatment was significant dialysis reactions. So all abnormal sequelae resulting from the interaction between blood constituent and hemodialysis membrane is the reaction. Many of these reactions were grouped in the past under the term first-use syndrome. They primarily occurred with the new dialyzer versus reused one. The dialysis membrane is, or the filter is not a simple, it's not a tube and loaded with fibers. It is composed of many chambers and coating material. And if you see the anatomy on the right side, it is made of many things that all may be interact and causing hypersensitivity and allergy. So The types of hemodialysis membrane, we have cellulosic membrane. This is the first was used. It's made of, as you know, from loaded cotton. And then the modified cellulose diacetate and triacetate. And this is still in the market. And we have the most popular, the synthetic, which is polyacryl nitrate and polymethyl acrylate PMMA and polysulfone. So all the dialysis membranes, they are either hydrophobic or hydrophilic. Hydrophobic, like in all the synthetic membrane, they repel water, and hydrophilic, they allow water to enter freely, but hydrophobic membrane should be rendered partially hydrophilic by blending them with certain material. The most used one is polyvinyl pyrrolidine, PVB, and polyethylene glycol. Usually, the more hydrophilic membrane, the more complement activation. So, type of membrane, we have the polysulfone family. Both polysulfone and polyether sulfone belong to the polyaryl sulfone group. They dominate in the market, 93% of synthetic membrane, 71 polysulfone and 22 polysulfone polyether sulfones. And they are commonly used by the big companies for dialysis, like Fresenius, Nipro, and Nikiso. And they are blend them with polymid, polysulfone, and polysulfone with vitamin E. The second group is polyacryl nitrate, PAN family members. The most popular is AN69 and AN69ST and AN69 heparin. This, before they are hydrophilic with sodium methyl cellulose, but now they change, they blend them with certain material. All of them, they are negatively charged with high electrogenicity. This gives a benefit of high absorption capacity, but they might affect some drug level, especially erythropoietins. Again, the third group is polymethyl acrylate, PMM family. The most, this is a famous Toray from Japan. It exhibits specific absorption features at their surface. The middle molecule beta-2 microglobulin is effectively absorbed in this wall structure, as well as serum-free light chains. PMMA membrane exhibit negative charge, same as argument as described in AN69. So, what is the mechanism of dialysis reactions? There are various mechanisms depending on the allergen. Usually, once the blood enters into the filter, it activates the common pathway and the alternative pathway. Common pathway leading to coagulopathy and activation of calgreen, and the alternative pathway lead to activation of mast cells, neutrophil, monocytes, and platelets. And these reflect on the patient, the patient will show different symptoms, maybe bronchospasm, fever, hypotension, according to the most affected line. So this is a slide show that the first use caprofen causing severe reaction through activation of C3A. The cellulose acetate cause less reaction, but when they reuse the filter or they use the synthetic polyacryl nitrate, the reaction will be reduced significantly. So the types of reaction, we have type 1 and type 2 reactions. The type 1 is the most severe anaphylactic and anaphylactoid reactions. Type 1 is rare, fortunately. It affects for over 100,000 patients with history of atopy or eosinophilia are prone to develop this kind of stress. Usually it happens in the first few minutes of dialysis and rarely after 30 minutes. So when you have reaction in the first few minutes, it is more, it's more dangerous and more, you should put iron on the patient, this type 1 reaction. It starts with itchiness, cough, sneezing, abdominal cramps. This is a mild headache, back and chest pain, fever, chills, but it might lead to severe dyspnea, impending doom, and cardiac arrest and death. The etiology, the famous etiology before was ethylene oxide. Now it's rarely used as a sterilizer. This can be, this material can act as the polyethylene coating material can act as a reservoir for this ETO. Then the residual ETO will enter the bloodstream and it's bind to plasma protein, causing severe reaction. Now it's replaced by gamma radiation, steam, and electron beam sterilization. There is a famous paper in early 90s about the anaphylactoid reaction secondary to AN69 and ACE inhibitors. And this happened in 57% out of the patient on AN69 with ACE inhibitor included in the study. And the reason was ACE inhibitor inhibit kininase, and this kind of filter in the beginning, as I mentioned, it vigorously generates bradykinin, and this bradykinin will stay in the circulation because of ACE inhibitors, and this causes vasodilation, pulmonary airway obstruction, and histamine release from mast cells. Same could happen when negatively charged polymers are used. So coating the AN69 membrane with biocompatible polymer like polyethelenamine neutralize this electrogenicity, then reduce the generation of bradykinin. We use now AN69 widely in Prismaflex, in ICU, and in CRRT machines. Again, PVP, which is, I mentioned, it is render the filter hydrophilic partially, used in most of the helix zone membrane from Fresenius, causing also many reactions. And we overcome this by changing the filter for the patients. So what is the etiology? It's contamination of the dialyzer with high levels of bacteria and endotoxins, particularly with high flux dialyzer. It occurs promptly in 2 minutes, and after initiating of hemodialysis, fever and chills are common. Treatment of type 1 reaction is to stop hemodialysis immediately, antihistamine, steroid, epinephrine, bronchodilators, and pressors. Prevention, prime the dialyzer well, and this is the most important, to eliminate any residual ETO, which is not used anymore, and other spirogenes. Avoid polyacryl nitrate membrane in patients treated with ACE inhibitors. Use more biocompatible membrane, switch to from ETO sterilization to gamma and steam sterilizer. Adequate sterilization technique for dialysis machine. So another way of prevention is pre-treatment with antihistamine steroid may be necessary in some patients, especially acute patients, whom you change the dialyzer frequently and they develop same reaction. Change heparin or stop it, and place patient on reuse program, which is no more use. Type 2 reaction is unspecified reaction, and they occur in 3 to 5% of patients with a new cellulose membrane. Symptoms much less severe than type A reaction. Chest with or without back pain, nausea, vomiting, and hypotension. Symptoms begin 15 to 30 minutes, little bit late than the type A reaction. symptoms improve with continuation of dialysis treatment. So diagnosis of type B dialyzer reaction is one, is exclusion, and you must exclude acute coronary syndrome, you must exclude other cause of acute respiratory distress. And it is mediated by complement, and the membrane activate the alternate pathway, complementing neutrophil activation, sequestration in pulmonary circulation, and marked transient neutropenia, as I mentioned before, in the first 15 minutes, but the band will be doubled in 1 hour. Management is supportive, oxygen, angina should be excluded. Dialysis can usually continue and change the dialyzer in the next session. Other reaction is thrombocytopenia, and I will mention this case, 69 years old female, end-stage renal disease in 2015 via right IgA perm cath. Comorbidity is diabetes, hypertension, ischemic heart disease, on aspirin 75 milligram, not taken regularly. As you see in this, on the right side, the catheter is in its place nicely, but it is with recurrent dysfunction. Right IgA perm cath change frequently. The blood flow is initially good, then it gets worse progressively. We DC the session usually in 1.5 or 2 hours. In November 2018, right IgA perm cath changed. Same problem occurred, Q weekly, and patient admitted in December for change the catheter. Bedside assessment was good flow. Canceled procedure. We just increased the low molecular weight heparin and advised the patient to take aspirin regularly. The catheter was good function. The platelet count can be reduced with first hemodialysis or few sessions of dialysis up to 9%, but not more than that. When you see the platelet decrease like in 50%, this means it's a kind of reaction leading to thrombocytopenia. So usually dialysis hypersensitivity is not, symptoms is infrequent, just the platelet will be decreased. So the mechanism is platelet surface degranulation. Platelet leukocyte aggregates have been detected in the dialyzer blood flow line, and the consequence of these is microcirculation are unknown. So this is nice case from literature, an adolescent with, and this is on the right side, his catheter, recurrent white thrombi formation in the hemodialysis tubing, associated with 60% decrease in platelet count. Light microscopy platelet aggregate resolved with increased heparin dose. So how to establish the diagnosis? As I mentioned, clinical suspicion is number one. Relevant history detailed about patient complaint, assessment of previous lab, rule out differential diagnosis, allergic test if applicable. We do also CBC, pre and 15 minutes and post-dialysis. C5a is difficult to measure. This Dugerdes criteria for defining type A reaction. You can see the criteria. You need 3 major criteria for definite diagnosis, or 2 major and 1 minor. For suspicion, you need either 2 minor and 1 major, or 3 minor. So conclusion, dialysis reaction are result of interaction between the blood and the different material of the dialyzer. They can be type A or type B hypersensitivity. Although they are rare, they could be very severe and life-threatening. The nephrologist and dialysis staff should be alert of this complaint, acting immediately. Chronic hypoeosinophilia with or without thrombocytopenia raise the suspicion of membrane reaction. Avoid polyalkylic membrane in patient with ACE inhibitor. Substitute with ARB for ACE. In severe reaction, stop hemodialysis immediately without returning the blood for sure. PVV may be increased probability of suffering of hypersensitivity reaction. And thank you.
Thank you. Thank you, Dr. Qutaiba. Now we move to the third talk in this session.